Jeff, you want to add anything to that?
Yeah, great comments. I totally agree that managed care gets a bad rap, that we do everything for cost. And that is, agreed, not true. Evidence drives everything we do. There are really what I call the big three things that we look at. It's comparative efficacy, comparative safety, and comparative cost, usually in that order. And when I say comparative, I don't necessarily mean head-to-head trials, but we're making comparisons. But having said that, I would like to take a second and just kind of talk a little bit about trends right now. So there are companies and services out there that monitor benefit design trends and spending trends. And what we are seeing is between the year 2000 and 2010, we saw a doubling in per member per year spend under the pharmacy benefit. And it's projected between right now and 2017, 2018, we're going to see another doubling in per member per year spend under the pharmacy benefit. So what we've done is we've taken a 10-year time frame to double. Now we're down to 4 or 5. Now this is being driven by specialty medications. So it's projected by 2017, 2018 that 50% of our budget under pharmacy is going to be quote-unquote specialty medications. Now oncology is the number 3 category within that, behind inflammatory disease and multiple sclerosis. Now this does not even include chemotherapy or the drugs under the medical benefit. This is only under pharmacy. So this is really an unsustainable trend, because ultimately it's our patients and our members that are bearing the brunt of those price increases. So it's imperative that the different stakeholders, which would be us as payers, you as providers, the member and the pharmaceutical companies, work together to manage these trends. So similar to what we just heard is, historically, what I have seen in health plans and PBMs is that we don't typically apply the traditional formulary management to oncology. So we're not going to P&T with the full review, where we're digging into the clinical data per se. So because we don't have the ability to make traditional formulary decisions, i.e. tiering or preferred drugs, and, based on contracting and everything else. So really what we do is, again, put prior authorizations on these drugs, as we just heard, and I totally agree with that. But I think a lot of people mistake prior authorization for pathways. And so these drugs typically get an abbreviated review right now, and it's to label. So we're really looking for an oncologist that's prescribing, and a diagnosis, and maybe a place in care depending on how the studies and the package insert, what that looks like. So the next step is going to be, as we've heard, is sequencing and applying the traditional formulary benefit design controls. So new drugs are always a good thing. It's good for our patients and our members because it gives them more opportunity and exposure to drugs that are going to benefit them, but it also helps managed care because now we have the opportunity to make comparisons among agents for efficacy, safety, and cost, and hopefully help direct decision-making to the most cost-effective medications.
So what's driving a lot of that is the fact that the path to FDA approval has been established and is, it seems, written in stone, right? So you compare it to the comparator that you guys negotiate as being the right comparator, docetaxel or whatever it is. But that ain't necessarily how the drug is going to be used when it hits the market. And so we got a lot of information about first line compared to something we might not ever use anymore. And it's funny, I had the privilege actually of taking care of a lot of prostate cancer patients, and I would talk to my friends in academia, and they would be very upfront about the fact that they had every intention of using every single drug in every single patient if they possibly could. So let me tell you something. Every single agent doesn't work in every patient in the way that the randomized trials say they work. There has got to be a sequence dependence. There's got to be it. But we don't know what the sequence dependence is. And so at the present time, Dr. X likes sequence A, Dr. Y likes sequence B, and we're not really learning a whole heck of a lot about what the right sequence ought to be.
And that's the challenge in prostate cancer, is you're exactly right. The sequencing is going to be a big issue. I think it's going to even go beyond that. I mean, we as clinicians are going to have to, with the aids of biomarkers and things like that, we're going to have to be able to take each individual patient, be able to sequence his or her tumor cell, whether it be prostate, breast, lung, being able to determine what particular genomic pattern this individual has, and whether or not each of these each of these therapies actually would be beneficial, because at that point, N equals 1. Each patient is his or her own trial. And I can, David, correct me if I'm wrong, but all these newer targeted therapies are all going to be oral agents, and the whole pressure on the pharmacy benefit side is going to continue to get worse.
So by and large, it's going to go across to the pharmacy side. Easier to give, but in some respects more difficult to control the costs, in that once you start a patient on therapy, they could be on for a long time, and it's not like you have an individual treatment like a surgery or a radiation period or an immunotherapy, where you give it and then it's done and the effect is ongoing or curative in some cases. You're looking at long-term palliation with a cost per month that does not drop.
So this is kind of a catch-22, being a clinician. It's nice to hear all this and about sequencing, but how do you study it? How does it go forth? I mean, in my mind, and Quinn's mind too, I think we know that all the cancers that we cure are not monotherapy. They're not sequenced A, B, C, D, E, and F. You put 3 or 4 drugs together and you might cure certain lymphomas and leukemias, and testis cancer was never cured by platinum alone. And so how do we go? I mean, we can talk about this, and we call up and beg to use this drug, and another clinician wants to use radium-223 first, another one wants to use Zytiga, another one wants to use Sipuleucel T and Provenge, and it goes on, and maybe I think there's data to put 2 of these drugs together, like enzalutamide and abiraterone, and so forth. It comes back. I ran the GU committee of Southwest Oncology Group for like 28 years, and it was really hard to get drugs paid for. Mandating coverage in clinical trials. So we need to do clinical trials, but we also need the coverage in clinical trials so things get done.
That's a great point, and I say this all the time. What the FDA requires of the manufacturers to get a drug approved is not the same thing that managed care needs. But the challenge is, given the expense of these drugs, who's going to pay for this? So this is really probably not the forum to talk about comparative effectiveness research, but we have to have funding to do that, because we need to go beyond the FDA approvals and even NCCN and really start talking about real-world evidence in making these sequencing decisions. Now, there are pros and cons to that. The pros are that we can actually use real-world data, that we can use input from our local oncologists in making these determinations, but then some of the challenges include that upon appeal and everything else, these are sometimes undefendable because you don't have the data necessarily or the strength of the data to support these types of decisions. So really, I totally agree with that. They need to be studied differently in different orders, and the sequencing needs to be approached.
We do in oncology.
But I don't think it's fair. I don't think it's fair to require the payer to fund to completely fund that.